Hello and welcome to another episode of Teaching Heroes, the teaching podcast where I ask teachers and educators, what does it take to turn up every day and teach tomorrow's leaders? And today, another episode of the COVID pandemic and how scientists and researchers have stepped up to educate the public on what it's like living in a pandemic. And I have the absolute pleasure of having Professor Greg Dore onto the podcast. Greg, thank you for coming on the podcast.
Great to be with you, Joanna.
Yeah, and it's so great to have you, and there's so much I want to ask about you, but what I have really enjoyed about being one of your fans on Twitter has been that you've got a really great sense of the nuance, Greg, and that's what I'm hoping that we can kind of talk today about, the nuance of public policy and also how we communicate to the public, and because I think it's something that's been lost, I feel.
Absolutely. I'm very happy to delve into that. Yeah,
great. And so, and also, you know, wanting to talk about how we move on into 2022. What year is it? What are we going to do?
Get to 2022 first.
2022. Because I think there's a kind of sense that maybe it's over. Is the pandemic over or not, or what's to come? And yes, it'd be great to get your expertise on that too.
A pleasure.
Okay, great. So first of all, tell, for those people who've been living under a rock and not quite sure who you are, Professor, who are you and what is your expertise?
I'm an infectious diseases physician and an epidemiologist. So in terms of my infectious disease work, I work at St Vincent's Hospital in Darlinghurst and have done for more than 20 years. I have specialised in the past in sort of viral hepatitis, set up Hep C clinics there back in the late 90s, but do some general infectious diseases as well. And I've been involved in the COVID sort of context, particularly in looking after people who have long COVID, so post-COVID illness. And we have quite a large number of patients that we see, and we have a large cohort of people post-COVID that we're following both for a clinical perspective, but also for research. So that's the infectious diseases side. I'm an epidemiologist working at the Kirby Institute, which is based at the University of New South Wales. And I've been also here for a long time, more than 20 years. My background originally was in HIV. I did my PhD in HIV. And then as I did clinically, moved into hepatitis C in terms of research. Did some work overseas, worked in East Africa for a while. And have been predominantly involved in hepatitis C work, both epidemiological research and also clinical trials. We've probably been the major group internationally leading on therapeutic evaluation for Hep C treatments in people who continue to inject. So very interested, involved in marginalised vulnerable population healthcare. That's been my sort of gig the last 2 decades or more.
Amazing. Mentally writing down a few other things to ask you about now. But let's go to March then 2020 in Australia, when the pandemic really hit us and we started to close borders. With your experience then, what was your reaction or to how we were performing in Australia, or what the public's reaction was back then?
Look, I was probably pretty naive in a sense. I certainly wasn't one of the early sort of adopters to the scale of what COVID would become. As I said, my sort of work had been in viral hepatitis. I'd been advocating for enhanced sort of research and action around viral hepatitis. So I was somewhat sort of jealous of all this sort of attention given to this other virus, and sort of originally, in a sense, railed a little bit against that. So it was really, I suppose, what was happening in northern Italy in sort of late February into March, early March, that made it very clear to me that this was a pandemic that was potentially going to cause a huge sort of burden of disease. And the rapid escalation of cases and severe disease in that part of the world, I think alerted many people to what we were faced with. I think Australia, to be honest, acted in general pretty well. We can look in hindsight about some of the decisions they made early, but they made decisions to sort of close international borders. We can talk about what that meant for stranded Australians and others sort of going forward. But in terms of trying to contain the scale of the epidemic sort of locally, I think the sort of early sort of weeks and months were pretty good, really. And the thing that, if you think back now to then, in that period in March, when we were sort of, the penny was dropping in terms of what we potentially could be facing, and some sort of early modelling sort of showed us that things could become overwhelmed pretty quickly if we didn't act. But all the discussion back then was about flattening the curve.
Yes.
It was about trying to limit the impact on our acute health care services, our hospitals, our intensive care capacity. And I think that was our strategy. We initially was articulated as trying to bend the curve. And then we were so successful in terms of the restrictions that we put in place, the sort of lockdowns that we went into, particularly in Sydney and Melbourne, and were able to sort of turn that first wave around. And I think everyone was sort of somewhat surprised at how effective we were at doing that.
Yeah. So back then, because you're a physician working in hospitals, back then, was there much groundwork laid into kind of, as you said, the narrative was about bending the curve. The expectation was that we would have an increase in cases. People kind of tended to expect that there would be quite a number of people ill, that we would need to increase the capacity of our hospitals. Did that occur? Was there a kind of build up?
So it was a really interesting time. I remember being on call, must have been about the sort of third week of March. And the infectious diseases physicians, we looked after patients in the community through our sort of hospital and home type sort of setup. So we were sort of contacting patients who were newly diagnosed and coordinating sort of care in the community, seeing how they were going and seeing who required sort of further assessment or potential sort of admission to hospital. The very sort of sick, severe respiratory patients were looked after in either intensive care or by the respiratory specialist. So we didn't have a lot of sort of involvement in terms of that very severe end of the spectrum. But there was a lot of preparation that was being done within the hospital itself, both in terms of the inpatient care and the sort of community-based sort of care, in terms of readiness, preparedness for what was expected to be a very large first wave. And we would have been more involved in the acute sort of hospital care as well if it had become much larger than it was in that first wave. And I remember thinking that I was going to be on call again in late April, and thinking, oh my God, it's going to be like horrendous by late April if the modelling sort of panned out. And the impact of restrictions wasn't what we saw it to be. We were going to sort of see a very, very large wave coming towards us by late April. And I was anxious about that. Not so much sort of personally anxious, but just anxious about the stress that would put on the system and the impact that would have on people. So it was a nervous sort of time in those weeks in the latter part of March 2020.
Yeah. And then, as you said, surprisingly, the curve flattened, and then we started to, get obsessed with donut days, and we can blame Anthony McCulley for that, I reckon. But so we started to talk about donuts. I was like, oh, wow, we can live in a no COVID society. But as you pointed to, the impact that then had on the mindset of us in Australia, and the continued closing of borders then left people stranded overseas.
Well, it was interesting. I've been through several sort of phases in the pandemic in my thinking. I think one of the sort of hallmarks of COVID is uncertainty. And I think as an academic and a spokesperson, as a communicator, you need to be able to sort of move with the evidence. You need to be able to admit when you've got things wrong. And I think you need to continue to, as you said early on, provide a more sort of nuanced sort of discourse. So it's interesting. I wrote a piece for the Sydney Morning Herald and Age in July 2020. In fact, as the cases of the second winter wave in Melbourne were escalating quite rapidly, and I actually said that I climbed on what I call the elimination bus, because I felt that the best way to approach it before we had sort of vaccines available was to try and achieve elimination, control of community transmission. Otherwise, it would spread very, very broadly and very rapidly and caused enormous sort of severe disease. By then, we'd also seen that Sydney controlled their first wave. We'd seen that New Zealand was able to get down to a zero community transmission. So I felt it was feasible. So I wrote a piece and said that I was climbing on the elimination bus. And it's interesting to think how I changed, I suppose. But I was very convinced that if we could achieve elimination and we could sustain that for a period of time, that vaccination eventually would be the solution. And even in July, I remember hearing Peter Doherty talk about sort of vaccine development, and he was pretty up about it. And I thought, well, if one of our national treasures, Nobel laureates, scientists, thinks vaccination is going to be going to get here sooner than we expected, and it's going to be pretty good, then I'll side with.
It was pretty spot on. I remember him saying, actually, still in my head, him saying, I'm quite bullish about it. We're going to have a vaccine in September. And that was when, Pfizer started to release and we started the vaccine.
Absolutely remarkable. And I won't name them, but there was a few other commentators that said it might take 2 or 3 years to get a vaccine. And also not only the length of time it might take to get an effective vaccine, but I think the expectation in terms of the level of infectious effectiveness was significantly lower than what panned out to be. So people were talking about 60 to 70% sort of effectiveness being a pretty good sort of goal. So when we got that first sort of trial data in September into October of 2020, it was remarkable, absolutely gobsmacking. So it was exciting, I suppose, as a scientist and an academic, to see the pace of that research, the sort of concerted effort. What can come of that is really incredible to see. Nothing comes close in terms of, I suppose, how quickly the advances were made from the first identification of the virus through to an effective vaccine within the same calendar year, really. Can we just take a sidestep, just deferring back to a point you made at the beginning around being a bit kind of jealous around, hang on, where's the attention on is there now a new sense for you to go, oh, hang on, what can be achieved in other infectious diseases then when such Absolutely. In fact, it's interesting, I'm part of an international consortium that's looking at advancing hepatitis C vaccine development. So we've set this up sort of recently, and there'll be leadership from the Kirby Institute. So the same, I think, will be the case in terms of HIV vaccine development. There's already an mRNA vaccine that's in early sort of phase trials. My hope is that this will advance absolutely infectious diseases research, and sort of there's no doubt that it has advanced public health understanding, or the community's understanding of public health and the importance of public health, and that should translate into I think enhanced investment in global public health, and it's important that it's truly global.
Yes, and I think that's a kind of a shift. There's been a bit of a shift, but I think a bigger shift in the public mindset around, our outstanding vaccination rates here is nothing compared to what is happening in other, lower socioeconomic countries that have just, you talk about on Twitter as well around, we're boosting here already when people overseas, there are some countries that have got a 20%, double dose vaccination rate.
Yeah, look, it's really tricky. I mean, I had my booster the week before last, in fact, and I had previously thought I wasn't going to have it until 2022. In fact, stated that on Twitter. just one of the other things I've got wrong. So, but I then sort of looked very closely at the evidence in terms of the booster data coming out, and it was pretty clear to me that this is a 3-dose schedule for a vaccination. It's like we have with hepatitis B. Several other vaccines are required to have 3 doses. So I think once you got to that realization, it was important that people have their 3rd dose to optimize the protection that they could have individually, and importantly, optimize the protection in terms of broader community spread. So I think the other thing that was happening was that there was some advances in terms of global vaccine equity. There'd been some announcement, particularly from the United States, in terms of their sort of investment, some increased donations into the COVAX facility, the international sort of group that's aiding access. And there's still a lot to be done on that front, but I think we can do things in parallel in terms of advancing boosters, as well as trying to provide some greater vaccine equity globally.
Yeah, and it's a bit, shooting your, what's that saying, shoot your hand off to spite your face or something like that. Like, because, we're throwing away vaccines here, take your booster, So, but it has meant, the mentality of Australians, I think, is still very much not aware of the impact of border closures, both internal and external. And as you say, we can, justify the approach up until the point of vaccination. And now, we really needed to shift, I think, a lot earlier than what we did.
Yeah, look, I think that there's a few things. I think in 2020, that there could have been a sort of greater understanding of the impact that these border closures were having on stranded Australians, and also on people trying to leave the country.
Yes.
It's funny, it never made any public health sense to me whatsoever that we stopped people leaving the country. I mean, the argument was that they would then join the queue for people trying to come back. But if I was someone who said, look, I'm happy to stay away for a couple of years until this pandemic's over, I just want to get out of the country. And we were sort of precluding that happening. Sure, people could apply for exemptions and so forth, but we were one of the only countries in the world to deny people exit. New Zealand didn't deny people exit. So that was always very odd to me. In terms of the cats coming in, they were very conservative. I think, look, the thing that really broke it for me was the India travel ban. And I think the fact that there was a sort of 2% positivity amongst the incoming international returnees, it was some sort of almost arbitrary sort of level that was sort of set. I think we went above it for about a week, and then everyone sort of panicked and we had the India travel ban. I just found that pretty abhorrent, to be honest. And I just thought that as a country, to make that sort of statement that we could see this a huge sort of epidemic in India, people that are being affected by that, and we were prepared to allow our own citizens to be stranded over there, was pretty remarkable. I thought that we could have, in fact, spent some money. We could have, in fact, sent plane loads of people back from India if we had the sort of willpower to do it and the empathy to do it. And that would have made a statement about the sort of country that we were. But in fact, we made the complete opposite statement, that we had no interest at all in their plight. And that, I was pretty affected by that. I thought that was just too much to handle.
And particularly in a country where we could see that their health systems were overloaded, that treatment wasn't easy. And I think people needed to get tested before they came on, but getting tested over there wasn't as easy as it was here, and the results weren't getting back, and therefore they were being pushed off the plane. I mean, and no public empathy for that either. And I guess that just really reflected the leadership that in that area as well. The same reaction.
It was interesting. I mean, I was pretty disappointed, to be honest, that there wasn't that many of my medical or even public health colleagues that were advocating strongly. In fact, I sort of buddied up with sort of human rights lawyers, academic lawyers, to write stuff around the plight of stranded Australians, and also some other stuff around global vaccine equity. And maybe, I suppose, my background in terms of working with vulnerable populations, marginalised populations, I just saw stranded Australians as another vulnerable, marginalised population. I never expected them to be, but that was how I viewed them. I didn't have any skin in the game at all. I don't have any close family overseas, so it wasn't that was sort of driving the sort of advocacy. It was, for me, just health and human rights, and that was pretty fundamental.
And I think it just wasn't aware, because I would have conversations with people, you know, around, there are 40,000 people stranded. Oh no, they can come home if they want. And I was like, no, people are getting kicked off planes. I still don't think people get the stranded nature of.
And it was also remarkable that, you know, rightly so, there were many people, particularly on the left, who were advocating for asylum seeker rights. And I've been someone who's been involved in that. I mean, I've done a lot of work in terms of trying to get access actually to Hep C treatment for people in immigration detention. So I've been a strong advocate for asylum seeker rights, healthcare access and human rights. But there were very few of those same people taking up the sort of plight of stranded Australians. And I just thought, this is really bizarre, like really bizarre.
My whole political, you know, feeling has just been upended, and I don't know where I stand now, to be honest.
You got to be very careful sort of asking certain questions in certain forums, I think, amongst friends and colleagues, because you can unearth some pretty interesting opinions.
Yes, I found that too. But I think partly, though, it's that there hasn't been that leadership in. Anyway, I don't know why people don't care more, but only yesterday, actually, because what I was going to ask you about was that even like temporary visa holders or people who were just holding visas couldn't, even though the border started to open to Singapore and other countries, that those visa holders couldn't leave and come back. But that's just changed as of yesterday.
Yeah, look, I think the other thing to say is that as we moved into 2021, look, we had some ongoing success in terms of our elimination type strategies. But then the Delta variant appeared. And once the Delta variant and its increased infectiousness took hold, it was bleedingly obvious that we weren't going to put the genie back in the bottle. So zero COVID was dead, certainly in Sydney and Melbourne. And we should have absolutely, flicked the switch straight away to loosening those sort of border restrictions in terms of travel. When you've got hundreds, if not thousands of cases a day, it just seems absolutely crazy that we would be concerned about a few cases coming from overseas. So it was that sort of inability, I think, for people to get their head around quickly what was happening in terms of the broader sort of spread of the virus and how minimal additional contribution it would make if we brought people back in much more readily. So I would have, as soon as it was obvious that zero COVID was over, I would have sort of, in a sense, almost thrown open the borders to people, particularly who were fully vaccinated. I would have let, visa holders sort of travel. I would have sort of moved much, much more quickly on that front, because when you're trying to contain things in elimination strategy, every case is important, so to speak. But when it's game over for zero COVID and the agenda is to accelerate vaccine coverage to get that sort of protection, particularly against severe disease, your strategy has to be able to pivot. And we just didn't seem to have the sort of flexibility or the sort of nous even to sort of pivot quickly to the new sort of world that we were sort of living in locally.
And you can see that in the slower uptake in other states, in like South Australia, Western Australia and Queensland have that slower uptake of vaccination. Because I just really noticed living in Western Sydney how quickly the community, once it was just, you started to know people that had COVID that were getting quite sick and knew people who died. It was just like the vaccine uptake was just so ridiculously quick. And I think that's what is obviously stalling it in other states. that there's not that same urgency. And if we opened up the borders and we said, okay, no more internal border closures, no more external border closures, I would imagine that that vaccine uptake would be quite rapid.
Yeah, it's interesting. I mean, I wrote a different piece in actually mid-January 2021. So Australia didn't have the vaccine at that stage, but obviously it started to be rolled out in the US and UK and other countries. And I sort of, said we needed to get vaccinated before winter. And I sort of wanted to create some urgency. But all we were doing is saying, oh yeah, we're fine. It's like, she'll be right. There's not a race. I just could not understand that. And these crazy scenarios were being thrown up that said that so the risk benefit, particularly when the severe clot sort of issue came with AstraZeneca, oh, well, our chances of having a major outbreak, someone even had it at 1 in 100. I said, these guys are completely loony if they think that's the level of risk we have of a major outbreak. So I was trying to push vaccination very, very hard in those early months through February, March, April. The severe clot sort of issue rose, and I sort of still pushed AstraZeneca absolutely, because I thought that the benefits far outweighed the potential low risk. But then we were sort of confronted by anti-AstraZenecism, and that sort of set things back somewhat. But look, to be honest, we did need a significant outbreak to break us out of that complacency. And once Delta arrived and we sort of jet propelled, the vaccine uptake, particularly in parts of Sydney that really needed it, through that period in August, when cases were rapidly sort of accelerating.
Yeah, and I saw you say another thing you were wrong about, very, very pleasingly so, was the high vaccination uptake. I mean, who would have thought we're nearly up to 95%?
Yeah, no, it's incredible. I remember giving an ABC TV interview, and it was around the time I think Gladys Berejiklian talked about getting 80%. The adult population, covered. And I said, well, that'd be great if we could do that. So yeah, my concern was that sort of surveys were sort of talking about hesitancies, in the order of 15 to 20%. But vaccine hesitancy absolutely fell off a cliff in those sort of weeks as the cases escalated in southwestern and western Sydney. And it was, the uptake that was sort of driven to a significant extent by the community response out there. It was just phenomenal and really encouraging. One of those great things in public health where you see a real response, come together with sort of a government commitment and people on the ground really committed to getting access to people that needed it.
So incredible. I tried to get a vaccination hub out of one of our campuses out at Blacktown, and it was, we didn't need it. The community out there was just like incredible. They just, pharmacies and the outreach, and I mean, they're over 95% now, I think, double dose, just incredible.
And I think what was important, I remember watching a video during that early period, and it was a video of Labor members from southwestern and western Sydney really coming out and supporting the vaccine sort of drive, and in a very sort of bipartisan sort of manner. And I've always said that public health is best when it's bipartisan, where you have you don't have sort of political sort of squabbling and point scoring. We've seen that with HIV, we've seen that with hepatitis C response. When you get bipartisan support for good public health, you've got your best sort of platform, and that's what works best with COVID as well. Absolutely.
What I guess one of my concerns is that, I mean, but it's less of a concern now that we can see how efficacious the lack of community transmission is now in such a high vaccinated population. But I do wonder, as we open up the borders and there's a kind of more cases, more people coming in, perhaps more variants, that the stigma around getting COVID, and I just wondered whether you'd seen that as a physician, that if people got COVID, they kind of saw it as a moral kind of failure that I think has been unique to the Australian experience, as opposed to overseas when, oh, well, if you got COVID, that's life living in a pandemic. Whereas here, if you get COVID, it's because you've done something wrong or you've been somewhere where you shouldn't have. Yeah,
look, it's interesting. Going right back to March 2020, and as I said, we were looking after patients in the community, then following them up, and we enrolled them into this ADAPT study that are leading from St Vincent's. And it was really interesting starting to sort of see some of those people post-COVID clinically, and they were stigmatized, there's no doubt about it, many of them. They also were incredibly isolated. So they're isolated in the sense that they have to spend the 2 weeks in isolation. They're isolated in the sense that even though we had a significant number of cases, it was still a very small proportion of the population that had been infected and affected by COVID. And there was still this sort of general anxiety and community uncertainty. So I think a lot of sort of the impact that patients back then were having in terms of the post-COVID experience, true, there was some physical sort of effects they were having, but also this intense sort of psychological impact, I think. And again, my background in terms of Hep C and people who inject drugs is very much around stigma and discrimination and those sort of issues. So you can see some sort of parallels that are obviously different on key levels, but some parallels in terms of how people were feeling and how they felt that the community was sort of looking at them, so to speak. I think in the current sort of context, there's still a bit of that issue in terms of we're still a very small proportion of the population's been infected by COVID. We didn't go to the UK and the US, and I mean, lots of people, friends, family members, and so forth, have been infected. So it's absolutely part of everyday life. It will become that at some stage in Australia. We'll have more cases, even though I'm confident we'll have higher vaccine rates going forward. We'll have a high uptake of the booster that'll keep cases under check to an extent. But I mean, this is a virus that's going to continue to circulate for years to come. So don't we need to get used to it? Most of us will probably be infected at some stage over the coming sort of several years.
I don't know. I think people are starting to shift. I have kind of noticed amongst friends, people are kind of starting to saying that they might get COVID. And I think that is what is, because that's the other kind of surprising thing, is that testing rates have still stayed so high in New South Wales. And I think that people are realising that it's not going anywhere, that if they've got a cold now, that they should go get tested while it's so readily available, because the chances are still high that they might get COVID.
Yeah, look, I think that if we sort of look forward in terms of what strategies are required, clearly high vaccine coverage, including the booster dose sort of coverage. But one of the other things that's essential is that we maintain high levels of testing. Now, before I said, look, it's likely that we may all be sort of exposed to the virus, but that doesn't mean that we don't try and contain spread. It still would be better to have less cases than lots of cases. I've always sort of felt that. So the way to limit spread is to diagnose cases early, so you can get those people into isolation. We won't have the same quarantine system that we've had through the last sort of 18 months or so. That'll be very different going forward. But we'll still, I think, tend to isolate people for at least a week or so. We'll also have the opportunity, if we diagnose cases early, to give them the new antiviral therapies, and they're looking pretty promising. So next year we'll have 2 different oral antivirals that are best used if they're commenced within the first few days after symptoms have developed. And that reduces your risk, particularly in the unvaccinated group, but also I'm sure in some people at high risk who are vaccinated, by what it looks like, potentially 80–85%. So to have access to those new treatments will be really important. But their best use, as I said, is if you diagnose people early. So we need to continue to test and broaden that access, not just to the sort of the standard testing, but also the rapid antigen test, which I think could be very useful going forward.
Yeah, right. Can we talk then a little bit about public health strategies and what we can, you think, like let go of? And you talk a bit about masks, and again, nuance, please, people, around masks, please, but around outdoor masks in particular. And I have to admit that when I was bushwalking with my husband in the middle of the pandemic, and outdoor masks were compulsory in Western Sydney, and I'd ripped mine off, and he goes, "But you're such an advocate for COVID strategies." But Professor Greg Dore said it's not necessary. So I'm in the middle of the bush, I'm not wearing a mask.
Okay, I like to think that I am not a terribly sort of complex sort of thinker in a way. I actually think that so much of this is common sense.
Yes.
So this is a virus that, sure, there's absolutely airborne transmission components of it. Aerosol transmission is real. I was a late adopter of the impact of aerosol transmission. I've said that sort of publicly. I was late getting on that. But it's very, very clear that the vast majority of, spread is indoors. And it just makes sense. You're outdoors, gets diluted very quickly. I just did not believe that outdoor masks could have much impact at all. And again, it comes back to, what are you trying to do? Okay, so, if you're in a zero COVID mindset where every single case is important, then you're trying to throw the kitchen sink at it, and even strategies that might have a minimal sort of impact. But when you've moved to the setting where, trying to control spread somewhat, obviously, then to have significant restrictions for what I think is minimal spread makes no public health sense at all. So as we go forward, if there's restrictions that are required to be brought back, I would have no restrictions on outdoor recreation or exercise, like none. If you want to go and sit in a park by yourself for 20 hours a day,
that rule was so ridiculous that you couldn't sit on a park.
I know. So, again, that makes no sense. Outdoor masking, unless you're in a large outdoor gathering, and where there's particularly an indoor-outdoor element. So, the cases at the Melbourne Cricket Ground, whether they're outdoor or indoor at the bar, etc. So I can understand that, densely sort of, populated indoor-outdoor settings. But otherwise, all the outdoor restrictions make no sense to me whatsoever. And all they do is they compromise people's quality of life. And people might say, well, an outdoor mask is easy. Well, it's relatively easy, but it's still some compromise to your quality of life. So you have to sort of consider that in the context of what you're trying to do. I've always been pretty sort of strong on, well, what's the evidence for this? I think the issue in Melbourne particularly was that during the sort of winter 2020 lockdown, they sort of threw everything at the escalating cases as a suite of interventions. They weren't really able to unpack everything to work out which was the most important ones. So then that was a natural sort of response. Next time you have a sort of outbreak, you throw everything, go hard, go early with everything. And I think the thing that broke the camel's back, so to speak, was when they closed playgrounds. Like, that was just like, okay, there's a large section of the community that was with you. Now you've lost a big chunk of people. And I didn't think that made any sense whatsoever.
And as you said, it's working again. It was interesting, that article that, when we heard about what Kerry Chant's recommendations were and what Gladys Berejiklian took up in New South Wales, and that, I don't think it's turned into this like, it doesnn't need to be. It's just like, this was a recommendation, they didn't take it up.
The other thing I'd say is that, I think Kerry Chant's done an amazing job in New South Wales, to be honest. Look, I actually was in the same year at university as Kerry. I've known her for a long time. We've worked closely on the hepatitis sort of front, and she's an amazing, public health figure. And I think she really has been one of the leaders in Australia. And so, she may have provided certain advice, and the Premier may not have taken all of that advice, but it's a situation where the Chief Health Officer provides advice. And the politicians can take all of that advice, some of that advice, they can discuss that advice, etc. I've never had a problem with the politicians saying, okay, I appreciate that advice, but I want to do things slightly differently for these reasons. And that doesn't dismiss the advice at all in terms of what the quality of the advice was, etc. And I think what she was saying, though, was that we wanted not to divide the city.
Consistently.
And I think that's what I sort of said on Twitter at the time as well. And even though I didn't agree with some of the restrictions that were put in place, I actually felt that it'd be better if the whole of Sydney sort of went with it.
Yeah.
I didn't agree with the outdoor sort of restrictions. I didn't agree with curfew, but I would have been happy to sort of adopt it across the sort of city.
Yeah.
We were sort of fortunate, it created a lot of attention, I think, in terms of a divided city.
Yeah.
But we managed to get beyond that tension because Southwest and Western Sydney was so committed and successful in terms of the vaccine drive. I think that really helped sort of build that bridge across the city again. But there's still some lingering animosity, I'm sure, in terms of the harshness of the restrictions in that part of the city versus the other parts of the city.
Yeah, it just got a bit ridiculous. In Southwest. Like my favourite coffee shop, although I think they there were police and military people there every morning, like about 4 or 5
at the coffee shop.
Standing outside I mean, I think it's because the coffee is amazing, but it was just that sense, and the helicopters flying over at all hours of the night, and at one time I realized I didn't have any cat food, and it was like 8:45 p.m. and I'm like, man, like I can't just go to Coles and get some cat food. That just felt so, and actually it meant that the supermarkets were fuller during the day because people then couldn't go at night.
It made no sense. I mean, again, the outdoor restrictions, what it has a tendency to do is keep people indoors. So if you just think about it logically, when outdoor settings like incredibly low risk, indoor higher risk, well, you should get people outdoors as much as possible. I mean, it just from very, very simple first principles. So a lot of that didn't make sense at all. It's interesting you talk about coffee and cafes. Sort of brings us to discussion of the first week that Sydney opened up. I don't know.
Oh yes, that's right.
Saw it on Twitter, but I went and had a coffee at my favourite cafe and posted on Twitter that it was great to sort of enjoy the simple pleasures of life again. And I was called a Nazi by a colleague, inverted commas, medical colleague, for dismissing the concerns of people working in intensive cares and so forth. It's been a strange world, I must say.
Considering your line of work and who you have been looking after, I mean, that was a bit...
it was a bit rich, I thought,
like who's actually on the ground. Because I think, like I've made this comment, talking to another one of your UNSW colleagues, Ben Harris-Roxas, and talking about how, the people on the ground who are actually kind of working in the area, working in communities, and as yourself as a physician, seem to, I think, have a better understanding of where the restrictions needed to go rather than people who weren't engaged in community or in the work at all. I reckon.
I think that it gives you some context. There's no doubt about that. Maybe I would have looked at things differently if I was in intensive care, though. I mean, maybe if I was confronted with that sort of impact of COVID on a daily basis, I might have sort of looked at things sort of differently. But what is important in public health is to be able to weigh up a range of different sort of impacts. And for me, there was no doubt that really sort of harsh restrictions or a pessimistic approach in general will have considerable downside, considerable negative impacts. And look, again, it's obvious that getting people outdoors, all that sort of shaming about people wandering along the Bondi Promenade on a nice sunny sort of spring day was just ludicrous, when health and well-being and mental health were absolutely pivotal in a time where things were pretty tough in terms of the restrictions. So to get that sort of balance right, I think is really important. And maybe having some involvement on the clinical side, but also a sort of broader public health understanding, I think, to contextualize that within is what gave me some sort of nuance in terms of what I was talking about.
It'd be great to hear about long COVID and what you're seeing the impacts of, and also in terms of, is there hope in recovery, or are people still lingering with symptoms. And
yeah, look, it's been really interesting. Again, one of the things that I sort of got wrong in a way is that I expected long COVID to be an illness where the vast majority of people would recover within, say, 6 months post-acute infection. That hasn't played out. I mean, we still have many patients that we're following 18 months post-illness. And we're sort of looking into reasons for that. We're doing some really interesting immunological studies to look at whether people have this sort of immunological fingerprint in terms of being exposed and having ongoing stimulation. And there's one theory is that there may be sort of remnants of the virus, not active infection as such, but remnants of the virus that keep triggering a sort of aberrant immunological response, a bit like a sort of autoimmune type disease. So that may open up some avenues in terms of interventions, therapies for people with long COVID. But there is definitely a small proportion of people that the symptoms extend beyond a year. And they can be really troubling. I mean, we have a lot of patients that were very healthy, like people running half marathons and so forth, and incredibly fit and healthy, and now are struggling. Now, if you look at the data, there's a few things that it tells you. One is that if you have really severe acute COVID, you're more likely to have post-COVID illness. That's not surprising. But even people that have relatively mild acute COVID can certainly have ongoing symptoms. The data around kids, I think, looks completely different to adults. And if you look at the good studies where they've had what we call cases and controls that are matched, and particularly kids under 12, really no signal at all in terms of significant long COVID. The older kids a little bit, but again, pretty low sort of prevalence. So that's important, I think, in the context of vaccination of kids, although I'm very in favour of vaccinating kids, including younger kids. But I'm not doing it because I think everyone's going to get like long COVID. So look, it's been interesting being involved in the long COVID sort of clinical area and the research area. And hopefully it will open some avenues for research in other post-viral conditions, also in chronic fatigue syndrome, in myeloencephalitis, so other sort of syndromes that are probably triggered by acute infections. There's a large number of people that are suffering because of those conditions that post-COVID illness may provide some answers.
Yeah. That's great. Well, I just looked at the time and I was like, oh man, I could talk to you for hours. So maybe we'll go have a coffee, Greg. We'll tweet it. But I really appreciate your time and expertise in coming on the podcast, and really appreciate your advocacy. I know I've got a lot of information from you. So, and I know that, and it really does take something to put yourself out there in the public realm like that. So I really have appreciated it.
A pleasure. And just to finish on a couple of sort of points, I think Australia is incredibly well set up if we sort of look to the future. A lot of people are concerned about what's happening in Europe, but what we've got is incredibly high vaccine coverage, particularly in the older age groups, but across the board. We're moving into summer, so we're benefiting from seasonality. We'll have the booster program rolling out to peak probably February and March. We'll be vaccinating, I'm sure, young kids probably from January, which will be important to keep schools open next year. And then we'll have our best sort of protection sort of heading towards sort of winter 2022. So look, I see Australia sort of sitting incredibly well in terms of where we are in the overall response. And if we'd had the same sort of population mortality rate as the UK or US, we would have had another 50,000 people die. So there's a lot to be proud of in terms of the COVID response in Australia. And we've done a lot of things right, we've done a few things wrong, but I'm feeling pretty optimistic about the future. Yeah, that's great. Thank you so much. Really appreciate it. A pleasure, Joanna. Yeah, this has been another episode of Teaching Heroes. We'll see you all next week. Bye.